Welcome to today's conversation with Dr. Zhang, a distinguished physician scientist in the field of oncology. Dr. Zhang brings a unique blend of expertise, being board certified in medical oncology as well as integrative and holistic medicine. His extensive research spans both laboratory investigations and clinical care, with a particular focus on cancer stem cells and off-label medicines. Dr. Zhang received his training at prestigious institutions such as Yale University and Memorial Sloan Kettering Cancer Center, where he honed his skills in both conventional and integrative approaches to cancer treatment. As a member of the American Association for Cancer Research and the Society of Integrative Oncology, he stays at the forefront of advancements in cancer care and research. Today, Dr. Zhang will engage in a dialogue with a patient on the most important topics and commonly asked questions regarding off-label medicine and cancer care. It's important to note that off-label medicine is an ever-changing and active research area, and as such, discussions will be based on the most up-to-date clinical and scientific research available. Let's start.
Hi, Dr. Zhang. I know you're a board-certified medical oncologist. I'm curious, what got you interested in using off-label medicine?
That's a good question. My journey into off-label medicine started back when I was an intern at Columbia. One of my senior residents was doing lab research on statins for colon cancer, and it really caught my attention. Then in 2001, after I graduated from Yale, I went to a free dinner that was a talk about Octos, which is a diabetes drug. While I was listening, I realized that the same drug Octos might actually work as a cancer treatment too, based on what I knew from cancer research. The drug blocks a key signaling pathway that cancer cells use. I decided to try prescribing Octos to a few of my patients, who had no other good options, including one with stage 4 colon cancer, and about a dozen with pancreatic cancer. Amazingly, they all lived much longer than what the textbooks said they would.
That's pretty interesting. What did you do next?
Back then, I really wanted to dive deeper into research. So I ended up moving to Baylor College of Medicine as an assistant professor. I was seeing patients a couple of days a week and spending the rest of my time in the lab with my postdoc. We got some funding from the Duncan Scholarship, which helped us pull together a team from Texas A&M, MD Anderson, and UT Houston. We put our heads together and came up with a plan to do high-throughput multi-drug screening. Basically, we used robots to handle tons of drugs and ran a huge number of experiments, all trying to find super cocktails against cancer using off-label medicines. We really focused on targeting cancer stem cells. Once we set everything up, we started seeing some early results. We also brought in this machine called Seahorse, which let us watch cancer metabolism happen in real time, especially things like mitochondrial respiration. Along the way, we found some really powerful combos, like Octos, sunitinib, and gemcitabine. But, like a lot of research stories, we eventually ran out of money and couldn't get more to keep it going. Even so, I've kept that spirit alive and still explore off-label medicines in my clinic today.
I'm really glad you're keeping the momentum going with the off-label treatments. So what can I expect during my consultation at Omega Precision Oncology Clinic?
At Omega Precision Oncology Clinic, we take a big picture approach to cancer care. Here's what we usually go over. First, we talk about diet and nutrition. We'll ask what you're currently eating, listen to any concerns you have, and give you personalized suggestions that can support your health and treatment. Next is supplements. A lot of people take vitamins or herbs, and we'll go over what you're using. We'll tell you what's helpful, what might be risky, and what's probably not necessary, based on science, not hype. We also use off-label medicines. These are repurposed drugs originally made for other conditions but may help in cancer care. We've put together a list of around 20 medicines we commonly work with, and we tailor them to your medical condition based on the latest research, and how you're responding to treatment. We'll also talk about other treatment ideas like intravenous high-dose vitamin C therapy, plasma exchange, and fecal microbiota transplants. We don't offer things like red light therapy or hyperbaric oxygen therapy, but we're happy to talk about them and any other modalities, give you an honest, science-based opinion. We also guide you through standard treatments like chemotherapy, immunotherapy, targeted therapy, and even low-dose chemotherapy. And if you've had genetic testing, like next-generation sequencing, or NGS, we can help you make sense of it. NGS looks at the DNA and mutations in your tumor to find possible targets for treatment. It's one of the tools we use to help personalize your care. Our goal is to bring together solid research, clinical data, treatment guidelines, and real-world experience, all in one place, working with you through shared decision-making. We're open to any treatment approach as long as there's real data behind it. But we don't recommend things just because they sound good in theory or showed early promise in a mouse study. We want what's safe, evidence-based, and truly helpful for you.
I'm really glad I'm meeting with you. You're not just a well-trained and experienced oncologist, but also a research scientist. I actually have a lot of questions about off-label medicines. But before we dive into that, let me ask you this first. Could you take a look at my diagnosis, my genomic profile, my cancer metabolism, the Warburg effect and all that, and come up with a treatment plan that's unique and personalized for me?
Thank you, that's a great question. It sounds like a really exciting idea, right? Crafting a totally unique and personalized treatment plan for each patient, and getting amazing success rates. But honestly, the short answer is no. Let me explain why. For decades, we are hunting for the key mutation, the so-called Achilles heel of cancer, hoping to design a drug that could wipe it out. And we did have some wins. Like chronic myeloid leukemia, where one mutation, the BCR-ABL, can be targeted and pretty much cured with one drug. But for most other cancers, even if we find a gene to target, the best we usually get is a few extra months of life, not a cure. And pretty soon, within months or maybe a year or two, the cancer figures out a way around the drug. The problem is how we look at cancer. We have been way too focused on breaking it down into tiny pieces. What we really need is a big picture approach, looking at cancer as a system, like systems biology. When you zoom in and look at details, like which genes are mutated or which pathways are switched on, let's say, the fat metabolism pathway in colon cancer, or the glycolysis pathway in many cancers, cancer looks different. Every patient seems a little unique. But if you zoom out and look at the whole system, you realize something more important. Deep down, all cancers are basically the same. Sorry, but nobody's cancer is truly one of a kind. They all share the same basic 10 hallmarks, whether it's colon, breast, or any other type. So if we really want to get rid of cancer, we can't just chase the so-called unique features. We have to hit all the common features, even the ones we can't see at the moment. Just because you don't see it doesn't mean it's not there. Maybe it's hiding out in your liver or lungs, just waiting. That's why trying to only focus on a few mutations or pathways is a bad idea. Instead, we need to attack all the pathways at once if we want a real chance to wipe cancer out for good. And while using many chemotherapy drugs at the same time would be way too toxic, unless you're treating something like acute leukemia, we can actually do this with off-label medicines. A lot of them are pretty gentle compared to chemo. In short, cocktails of off-label medicines and supplements are a much better strategy than trying to create a super customized plan or personalized protocol based on one patient's specific mutations. It's about using everything we know about cancer biology today to build a treatment that covers all the bases.
How does the off-label combination therapy work?
This cocktail targets multiple cancer hallmarks at the same time. Rather than focusing on just one pathway, these drugs are designed to interfere with several key mechanisms that cancer cells depend on, such as energy metabolism, immune evasion, inflammation, and cell survival. The goal is to weaken the cancer cells by disrupting these critical functions, and to modify the tumor microenvironment so it's less supportive of cancer growth. By doing this, we increase the effectiveness of traditional therapies, like chemotherapy, radiation, or immunotherapy. It's a systems-based strategy that works across cancer types by hitting shared vulnerabilities.
I read Jane McClellan's book, How to Starve Cancer, and she mentioned the MetroMap for cancer metabolism. Does the off-label medicine cocktail cover all those pathways?
Absolutely. The off-label medicine cocktail interferes with the metabolic networks that cancer cells rely on to grow and survive. This idea lies at the heart of cancer metabolism, which is a key focus within the broader field of systems biology and systems medicine, fields that aim to understand and disrupt the interconnected processes cancer cells use to thrive. As I mentioned earlier, our approach is centered around targeting the core hallmarks of cancer. Metabolic reprogramming, which Jane illustrates in her MetroMap and emphasizes throughout her book, is one of the 10 hallmarks. Cancer cells often depend on aerobic glycolysis, also known as the Warburg effect, where they rapidly consume glucose even when oxygen is available. But that's only part of the picture. Many also rely on alternative fuel sources like glutamine, fatty acids, and even lactate, to support their energy needs and build new cells. The off-label protocol we use is designed to block multiple points across these fuel pathways. It not only restricts the cancer cell's primary energy sources, but also makes it harder for them to switch to backup fuel routes, like glutamine metabolism. Over time, this can weaken the cancer's ability to grow, spread, or resist treatment. By limiting their access to fuel and disrupting their adaptive mechanisms, metabolically stressed cancer cells may become more sensitive to chemotherapy, radiation, and immunotherapy. And yes, our combination therapy is mapped to cover all major metabolic pathways featured in the Metro map, using a layered and coherent approach, supported by published research data and clinical insight. Last but not least, I want to add that the cocktail we use doesn't just interfere with cancer's fuel metabolism, it also impacts cancer stem cells, inflammation, and several other cancer hallmarks that go beyond what's shown in the Metro map. This broader and systems-based strategy is what gives our approach both flexibility and strength.
Who is the off-label medicine cocktail intended for? Does it apply to my type of cancer?
The off-label medicine cocktail we use targets the core hallmarks of cancer, biological traits that are shared across almost all cancer types, no matter where they start or what stage they are in. These include abnormal ways of producing energy, heavy dependence on certain nutrients, chronic inflammation, stress survival mechanisms, cancer stem cell activity, and the ability to evade the immune system. These features allow cancer cells to grow uncontrollably, avoid death, invade other tissues, and resist standard treatments. The concept of cancer hallmarks was introduced to explain the shared strategies that cancer cells use to survive and spread. While each cancer may look different on the surface, at a deeper level, they rely on similar biological processes. Our approach targets several of these processes at the same time, especially those related to metabolism, inflammation, immune evasion, and stemness. Because these traits are common across many types of cancer, our protocol is considered cancer agnostic. It may be appropriate for patients at any point in their cancer journey, whether newly diagnosed, in remission, or facing progression. Instead of focusing solely on tumor type or genetic mutation, we take a systems biology approach, addressing the underlying weaknesses that most cancers share. This makes our strategy broadly applicable to most cancers, and often complementary to chemotherapy, immunotherapy, radiation, and other conventional treatments.
How many off-label medications are actually used in cancer treatment? And which ones are most commonly used at your clinic?
Great question. There are actually a lot, well over 100 off-label medications, have shown potential in cancer care, based on lab research and clinical studies, as well as case reports. Some of the better-known ones include metformin, mebendazole, ivermectin, doxycycline, statins, and celecoxib. Certainly we don't use all of them for every patient. We carefully choose the list based on available clinical data, how the patient is doing, how the medicine fits with their standard cancer treatment, and whether there are any important drug interactions. And just to clarify, not all drug interactions are bad. In some cases, they can actually make treatment more effective, when used the right way. At our clinic, we more commonly use medications like metformin, mebendazole, itraconazole, doxycycline, celecoxib, pitavastatin, propranolol, hydroxychloroquine, and sometimes dipyridamole, pioglitazone, ivermectin, and occasionally others like niclosamide, disulfiram, and dimethyl fumarate. We base our choices on a mix of real clinical experience, published research, and a solid understanding of the pharmacology behind each drug, how it works, how it interacts with other medications, and how it might influence treatments like chemotherapy or immunotherapy. And I should add, our approach is usually not based on the cancer type. Instead, we take a more cancer-agnostic approach. Like I've mentioned before, we see cancer as a systems biology issue. We're focused on targeting the shared hallmarks of cancer, those common traits that almost all cancers rely on to grow, spread, and survive, no matter where they started.
How do I know if the treatment I'm getting at Omega is actually helping me?
At Omega Precision Oncology, it's not always easy to pinpoint which part of your treatment is making the biggest impact, whether it's the integrative protocol we offer or the standard therapies you're also receiving. The reality is, both are backed by strong research, and in practice, they often work together in a complementary way. Rather than trying to separate which element is doing what, our focus is on helping you get the best overall result. We base our approach on clinical studies and a thorough review of the medical literature, but we also recognize that every patient's journey is unique. Most of the time, it's the synergy between your conventional treatments and our integrative strategies that creates the strongest effect.
How will you track my progress while I'm taking off-label medications and supplements?
We monitor your progress using a combination of imaging and lab tests. This includes scans like CT, MRI, or PET, along with tumor markers such as CA15-3, CA2729, CEA, CA19-9, and AFP. Most of the time, your primary oncologist will already be ordering these as part of your standard care, and sharing the results with us allows us to adjust your protocol if needed. We also use advanced molecular tools like Signatera and Guardant Reveal to track your tumor burden more precisely through circulating tumor DNA. These tests give us a real-time view of how your cancer is responding at the molecular level. In many cases, your oncologist may already be ordering them, but if not, we can help you get them set up. While these are high-end tests, Signatera and Guardant Reveal are often covered by insurance.
Thank you. Can you briefly explain the 10 hallmarks of cancer?
Sure, happy to explain. So, the 10 hallmarks of cancer are basically the common moves cancer cells make to grow, survive, and spread. No matter what kind of cancer we're talking about, breast, colon, lung, they usually follow the same playbook. First, they just keep growing and dividing, even when your body tells them to stop. And unlike normal cells, they don't die when they should, they sort of become immortal. They also figure out how to build their own blood supply, so they can keep feeding themselves. That's how tumors get bigger. They don't respect boundaries either. They push through tissues and can travel to other parts of the body, which is what we call metastasis. Plus, they're sneaky, they know how to hide from the immune system, so your body doesn't fight them off effectively. They also change how they make energy. Instead of using oxygen the normal way, they switch to burning sugar fast, which helps them grow even faster. And they stir up inflammation, which actually helps them out instead of hurting them. Finally, they mess with their own DNA to evolve quickly and hijack normal survival signals. Bottom line, different cancers may look different on the surface. They might have different mutations or unique features. But underneath, they all use the same set of tricks to some degree.
So, how long am I supposed to stay on this off-label medicine combination?
At Omega Precision Oncology Clinic, the duration of your treatment protocol depends on your ongoing cancer care plan and other individualized factors. This is something we'll continue to discuss during your appointments. For patients at average risk, our general approach is to maintain the protocol for about 2 to 3 years, followed by a gradual reduction in medication intensity. The medications and dosages are tailored over time based on your treatment response, standard of care therapies, and tolerance. Once you reach the 3-year mark and are doing well, we will reassess long-term benefits and risks. Some medications we use are safe for lifetime use, while others are more appropriate for shorter-term courses, such as 2 years. We will revisit and adjust the plan as you reach the key treatment milestones.
What blood test should I do in order to keep an eye on side effects from my off-label medications?
The blood test panel we use includes a complete blood count, CBC, and a comprehensive metabolic panel, CMP. The CMP checks your kidney function, things like BUN, creatinine, and calcium, as well as your liver function, including bilirubin, ALT, albumin, alkaline phosphatase, GGT, globulins, and total protein. We also check vitamin D levels and G6PD. We typically don't include tests like hemoglobin A1C or cholesterol panels, even though some of the medications we use were originally developed for diabetes or high cholesterol. That's because in our clinic, we're using these medications as part of a cancer treatment strategy, not to treat diabetes or lipid issues directly. Regular testing of CBC, CMP, vitamin D helps us monitor for side effects that might affect your immune system, blood counts, kidney or liver function, and to make sure it's safe for you to continue high-dose vitamins or supplements. These tests are important for your safety. In many cases, your oncologist may already be ordering these labs, so we just need a copy of the results. You can usually access them through your MyChart account or directly from your oncology clinic. If you're having trouble getting the tests done, we can help by placing an order for you through Quest Diagnostics. The process is done online, and both you and our team will have access to the results at the same time. Most of the time, these lab tests are covered by insurance.
How often should I have blood tests done?
We usually recommend doing blood works like a CBC and CMP every 1 to 3 months, to keep an eye on any potential side effects. This helps us monitor things like your liver and kidney function, blood counts, and overall safety. The exact timing may vary depending on your treatment plan and how you're feeling, so we'll tailor the schedule to your specific needs.
Can I share the blood test results I get from my local oncologist with you?
Absolutely. Sharing your lab results with us helps us stay in sync with your overall care team and avoid repeating tests unnecessarily. It also allows us to make better informed decisions about your treatment while keeping things simple and coordinated for you.
What should I do if my blood cell counts go down while I'm taking off-label medications from Omega Precision Oncology?
If your blood counts fall, pause your medications temporarily and repeat your lab work in 1 to 2 weeks. Make sure to go over the results with both your primary oncology team and Omega Precision Oncology. Many standard treatments, not just off-label therapies, can influence blood cell levels, so coordinated review is key to making safe and informed decisions.
What should I do if my liver function tests come back abnormal after starting treatments prescribed by Omega Precision Oncology Clinic?
If your liver tests are abnormal, the first step is to pause the treatments prescribed by Omega Precision Oncology Clinic, and repeat the blood work in about 2 weeks. It's also important to inform your primary oncologist. Liver changes can be caused not only by off-label medications and supplements, but also by chemotherapy, oral targeted therapies, or immunotherapies like Keytruda. Keeping your entire care team informed allows everyone to work together to evaluate the cause and adjust your treatment plan safely.
What should I do if I have nausea or vomiting while on treatments from Omega Precision Oncology Clinic?
If you experience nausea or vomiting, it's best to pause the treatments prescribed by Omega Precision Oncology Clinic and see if your symptoms improve. Be sure to also talk to your treating oncologist, since many standard cancer treatments, like chemotherapy, targeted therapy, or immunotherapy, can also affect your digestive system. Keeping both teams informed helps ensure your care stays safe and coordinated. I want to review your current medication list and explain which ones are more likely to cause nausea or vomiting. The medications that commonly cause nausea or stomach upset include metformin, doxycycline, itraconazole, disulfiram, sulfasalazine, and dimethyl fumarate. These side effects often appear in the first few weeks but usually improve over time. Taking them with food and plenty of water helps reduce discomfort. A few medications can cause nausea occasionally, such as celecoxib, hydroxychloroquine, albendazole, or mebendazole, and niclosamide. The rest, including pioglitazone, pitavastatin, propranolol, ivermectin, dipyridamole and diclofenac only rarely cause nausea or vomiting, and most patients tolerate them well. If you notice any persistent nausea or vomiting, please let us know right away. We can adjust the dose or timing, or use supportive options to help. Usually, these side effects are mild and temporary.
What should I do if I feel dizzy while on treatments from Omega Precision Oncology Clinic?
Some of the medications prescribed by Omega Precision Oncology Clinic can occasionally cause dizziness. If you start feeling dizzy, pause the treatments and see if your symptoms improve. It's also important to let your primary oncologist know, as dizziness can also be a side effect of many standard cancer treatments. Keeping both care teams informed helps us evaluate the cause and adjust your treatment safely. I want to review some medications and explain which ones are more likely to cause dizziness. The medication most often linked to dizziness is dipyridamole, which is considered very common. That means dizziness happens frequently, especially when standing up quickly. The other common causes of dizziness include propranolol, disulfiram, itraconazole, sulfasalazine, and dimethyl fumarate. These can sometimes make you feel lightheaded or off balance, particularly during the first week or when you change positions too fast. Dizziness is uncommon with pioglitazone, ivermectin, celecoxib, diclofenac, hydroxychloroquine, niclosamide, and doxycycline. It's considered rare with pitavastatin, mebendazole, and metformin. If you ever feel dizzy or lightheaded, especially after starting or adjusting your medications, take your time when getting up, stay well hydrated, and let us know. We can review your blood pressure, medication timing, or make adjustments as needed.
I'm experiencing significant diarrhea while taking off-label medications. What should I do?
Temporarily hold your medications and observe whether your symptoms improve. Diarrhea can be caused by many cancer-related treatments, not just integrative or off-label therapies. Make sure to discuss your symptoms with both your primary oncology team and Omega Precision Oncology, so your care can be adjusted appropriately and safely. Just so you know, some of the medications we often use here at Omega Precision Oncology can cause diarrhea, sometimes pretty commonly. It's something to keep an eye on. Here are some of the medicines that most often cause diarrhea in varying degrees, from mild loose stools to watery diarrhea, sometimes accompanied by stomach upset. Metformin, which can affect up to about half of patients. Sulfasalazine, seen in about 1 out of 5. Mebendazole, around 3 to 10%. Dimethyl fumarate, roughly 14 to 18%. Diclofenac ER, about 5 to 15%. Hydroxychloroquine, up to 10%. And doxycycline, which can also cause symptoms in about 5 to 10% of people. If you start noticing loose stools, cramping, or any stomach discomfort, it could be related to one of these medicines. Let us know early so we can help manage it and keep your treatment on track.
What's the best way to take these medications?
Some medications work best when taken with food, others on an empty stomach, and some can be taken either way. Understanding when and how to take your medications helps improve both their effectiveness and how well you tolerate them. For example, metformin and mebendazole should be taken with meals. This not only helps the body absorb the drug more efficiently but also reduces stomach upset. Doxycycline and many other medicines, on the other hand, are more flexible. You can take them with or without food, whichever fits better into your routine. If you're fasting, metformin is generally safe to continue. But it's important to stay alert for signs of low blood sugar, things like dizziness, sweating, or feeling shaky. If that happens, pause and reassess. And always feel free to reach out to your care team for guidance. These little adjustments can make a big difference in keeping your treatment on track while protecting your well-being. Let's talk about medications that should be taken with meals. Taking these drugs with food can improve how well your body absorbs them, and can also help reduce stomach upset. Metformin, taking it with food helps reduce nausea and diarrhea. Mebendazole, or albendazole, they're better absorbed when taken with a fatty meal. Itraconazole, these work best when taken with food and an acidic drink, like orange juice, to help absorption. Sulfasalazine, taking it with meals and plenty of water lowers the risk of stomach irritation. Niclosamide, also absorbed better with fatty foods. Dimethyl fumarate, taking it with food helps lessen flushing and diarrhea. Celecoxib, food helps lower the risk of stomach discomfort. Diclofenac, best taken with food to reduce stomach toxicity, and support safer long-term use. In short, pairing these medications with a meal helps your body absorb them more effectively, and keeps your stomach comfortable. Now, let's talk about medications that should be taken on an empty stomach. Some medicines work best this way. Take them at least 1 hour before, or 2 hours after a meal. This helps your body absorb them better. Disulfiram is one of these. It's absorbed more effectively without food. If it upsets your stomach, it's okay to take it with a meal. But remember, no alcohol at all while on this medication. Dipyridamole is another one. It's best on an empty stomach for full absorption. If it makes you feel nauseous, you can take it with food instead. Ivermectin is a bit different. Traditionally, it's taken on an empty stomach for parasite treatment. But in our anti-cancer programs, we pair it with fatty foods. That helps boost absorption and make it work more effectively. Next, let's go over medications that can be taken with or without food. These drugs are flexible. Just try to be consistent with how you take them each day. Doxycycline. Take it with food if your stomach feels upset, but avoid dairy. Atorvastatin and pitavastatin, also known as Zopetamag, can be taken with or without food, though bedtime is often preferred. Propranolol, with or without food, but take it the same way every day for steady levels. Hydroxychloroquine, taking it with food may help reduce nausea, but it's not required. Pioglitazone, food optional, just take it at the same time each day. Now, a quick note about doxycycline. It comes in two forms, hyclate and monohydrate. Both work well, but doxycycline monohydrate is often easier on the stomach. It's less likely to cause nausea or digestive discomfort, making it a better choice for people with sensitive stomachs. So here's the deal, most of these meds can be taken with food, no problem. The main exceptions are dipyridamole and disulfiram, which are generally recommended on an empty stomach for better absorption. But honestly, if they upset your stomach, it's totally okay to take them with food instead. Comfort matters. Now, a few of these actually work better when taken with a fatty meal, especially when we're using them in cancer care to boost absorption. Ivermectin is one of them. Fatty food significantly increases how much your body absorbs, and we use that to our advantage. Celecoxib is another. A high-fat meal helps it absorb better and also eases potential stomach irritation. Itraconazole, specifically the capsule form, is best taken with a fatty meal too. Just a heads up, the liquid version actually works better on an empty stomach. Niclosamide isn't as well studied in this area, but there's some evidence suggesting that fat may help its absorption, especially when we're using it for things like cancer, not parasites. And mebendazole, definitely take it with fat if you want it to work throughout the body and not just in the gut.
Is it better to start all my medications at once or introduce them one at a time?
To minimize side effects and help identify any possible reactions, it's best to start medications one at a time. This approach makes it easier to see which drug might be causing a problem if one comes up. By adding them gradually, you give your body time to adjust. And you give your care team the clarity they need to guide you safely.
In what order should I introduce these medications?
The specific order isn't critical. What matters is starting one medication at a time, with about 3 days in between each new one. This spacing helps you clearly notice any side effects and gives your body time to adjust. Keep a simple calendar or medication diary. Write down when you start each drug, and note any symptoms you experience. If something shows up after adding a new medication, make a note. Then pause that medication and watch if the symptom goes away. If it does, write down when it disappears. Later, try restarting that same medication. If the symptom comes back, that confirms a likely link between that drug and the side effect. Share this with your care team. We can adjust the dose, change the timing, or switch to a different formulation to help you tolerate it better.
I understand there's no required order for starting these medications, but could you give me an example I can follow?
Certainly. While the sequence isn't set in stone, a smart approach is to begin with medications that have the lowest risk of nausea or vomiting, and gradually work up to those that are more likely to cause gastrointestinal side effects. This gives your body time to adjust, and helps identify any side effects more clearly. Here's a sample order, space them out by 3 days each. Pitavastatin, propranolol, dipyridamole, pioglitazone, ivermectin, celecoxib, disulfiram, diclofenac, hydroxychloroquine, mebendazole, niclosamide, doxycycline, itraconazole, sulfasalazine, metformin, and dimethyl fumarate. Of course, you may not be prescribed all of these medications. If something isn't part of your personal treatment plan, for example, not everyone uses disulfiram or dimethyl fumarate, just skip it. Focus on the ones that are relevant to you. Keeping a medication diary, or marking your calendar with start dates and any side effects, can really help both you and your care team monitor your progress and adjust as needed. For your reference, and to help you set expectations, it may be helpful to see how these medications compare in terms of nausea and vomiting risk. Below is a general ranking from least to most likely to cause gastrointestinal upset. This overview can give you a clearer mental picture as you work through your treatment plan. Knowing this in advance can help you plan your med schedule and recognize side effects early. Always feel free to reach out if symptoms arise. We're here to help fine-tune your treatment so it works with your body, not against it. From this list, you can see that pitavastatin, propranolol, dipyridamole, and pioglitazone rarely cause stomach or digestive issues. In contrast, it's very common to see gastrointestinal side effects with doxycycline, itraconazole, sulfasalazine, metformin, and dimethyl fumarate. Mebendazole falls somewhere in between. Feel free to take your time reviewing this information. You may find it helpful to pause, jot it down, or print a copy for easy reference as you move through your medication plan. Having this list nearby can make it much easier to track symptoms, stay organized, and have informed conversations with your care team.
Should I alternate the off-label medications? Like taking mebendazole in the first month, doxycycline in the second, and then back to mebendazole in the third?
No, we do not recommend alternating these medications month by month, or cycling them individually. The strength of this approach lies in the synergistic effect that results from using all the agents together. Each one targets a different aspect of cancer cell metabolism, and when combined, they create a more comprehensive disruption of the cancer cell survival mechanisms. This multi-targeted strategy may also enhance the effectiveness of standard treatments, such as chemotherapy or radiation. If tolerance becomes an issue, we can adjust the dose, or provide breaks as needed. However, the overall goal is to maintain all medications together and consistently, rather than using them in rotation.
What if I experience side effects or have concerns about the medications and supplements?
If you notice any side effects or start to feel unwell, it's important to stop the medication or supplement, and reach out to us right away. Common side effects may include nausea, vomiting, abdominal cramping, fatigue, dizziness, fainting, muscle aches, diarrhea, changes in urine color, or skin discoloration. We can adjust your treatment plan to help reduce or manage these symptoms. Everyone responds differently, so open communication is key. Letting us know how you're feeling allows us to make sure your treatment stays safe, effective, and tailored to your needs.
What are the common side effects of pitavastatin? And when should I take it?
Pitavastatin, also known by brand names like Zopetamag or Livalo, is a cholesterol-lowering medication in the statin family. Like all medications, it can cause some side effects. The most common ones include muscle pain or weakness, reported in about 2 to 9% of patients, depending on the dose, constipation, 1 to 3%, diarrhea, less than 2%, and back pain, 1 to 2%. Some people also report mild rash or extremity pain, but those are rare. Pitavastatin can occasionally raise levels of creatine kinase and liver enzymes, usually in 1 to 3% of people, though serious changes are uncommon. In very rare cases, patients may experience increased blood sugar levels, memory fog, or confusion. An extremely rare side effect that has been reported in case studies is lichen planus, a skin condition. As for when to take pitavastatin, the good news is you have some flexibility. Unlike older statins that must be taken at night, pitavastatin can be taken at any time of day, thanks to its long-lasting effect. Some people still choose bedtime dosing since the body makes most of its cholesterol overnight, but what matters most is picking a time you can stick to consistently. And don't forget, routine blood work is recommended to monitor liver function and muscle health while you're on this medication.
What are the side effects of propranolol?
Propranolol is generally considered safe and well tolerated, with a long track record in managing cardiovascular and neurologic conditions. However, like all medications, it can occasionally cause side effects. The most commonly reported side effects include fatigue, dizziness, and occasionally gastrointestinal symptoms such as nausea, diarrhea, or constipation. These usually appear early in treatment and often improve over time. Because propranolol lowers heart rate and blood pressure, some individuals may experience bradycardia or hypotension, which can cause lightheadedness or fainting. It may also lead to sleep disturbances like insomnia, or mood changes such as depression in a small percentage of users. In rare cases, propranolol may affect sexual function, leading to impotence, or cause allergic-type reactions like skin rashes or hair thinning. It's important to remember that most people tolerate the medication well. Any concerns or unusual symptoms should be discussed with a healthcare provider so the treatment can be adjusted if needed.
What are the common side effects of dipyridamole?
The most common one by far is headache. In fact, in one study, about 67% of people reported headaches on the first day of taking it, but the good news is that number dropped way down to just 3% after a few days. Your body gets used to it pretty quickly. Other possible side effects include feeling dizzy, around 3% to 8%, nausea, 2% to 5%, and flushing or feeling warm, 3% to 6%. Some people also notice low blood pressure or lightheadedness, diarrhea, stomach pain, or even vomiting, but those are less common, usually in the 1% to 3% range. A small number of people, about 1%, may get a rash, feel their heart race a bit, or experience ups and downs in their blood pressure. Most of these side effects are mild and tend to settle as your body adjusts.
What are the common side effects of Actos, or generic pioglitazone?
Pioglitazone is generally well tolerated, but like all medications, it can cause side effects, most of which are mild and manageable. Here's a breakdown of the most commonly reported reactions. Upper respiratory tract symptoms happen in about 8% to 13% of people. But don't worry, these usually aren't real infections. Most patients just notice a runny nose, mild congestion, or allergy-like symptoms, not true colds or flu. Headaches are fairly common too, seen in around 5% to 9% of patients. These are usually mild and don't last long. Muscle aches or myalgia can affect about 2% to 5% of users. If you already deal with joint or muscle discomfort, it's something to keep an eye on. Weight gain may occur, particularly at higher doses. About 2% to 10% of people report gaining weight. It's often due to fluid retention, not just fat gain. Edema or swelling, especially in the legs or ankles, can happen, and it's more likely if you're also on insulin. Gas or flatulence is reported by about 2% of patients. It's not dangerous, just a bit uncomfortable. Most of these side effects improve over time or with dose adjustments. If you notice anything unusual or bothersome, it's always best to check in with your doctor.
Are there any serious side effects of pioglitazone?
Yes, there are a few serious side effects to know about, though they're pretty rare. Most people do fine on pioglitazone, but it's still good to be informed, especially if you're taking it long-term or already have certain health issues. Let's start with congestive heart failure. Pioglitazone can sometimes make heart failure worse, especially in people who already have heart problems. The risk goes up with higher doses or longer use. In folks with known heart conditions, about 1% to 5% might experience symptoms. Because of this, the FDA gave pioglitazone a black box warning, the strongest warning they issue. Next, there's the risk of liver problems. Serious liver injury is very rare, less than 0.5%, but it's been reported. That's why your doctor may order some liver function tests when you first start taking it, just to be safe. Bladder cancer has also come up in some long-term studies. There's a small bump in risk, especially if someone's been on Actos for more than a year. The estimated risk is around 0.5%. That doesn't mean the drug causes bladder cancer, but it's something we keep in mind, especially if there are other risk factors. Then there's the topic of bone fractures, especially in women. With long-term use, there's a slightly higher chance of breaking a bone, usually in the hands, feet, or arms. The rate is about 5% for people taking pioglitazone over several years, which means the overall increase in risk is small, roughly 1 to 3% above normal. Now, I know that sounds like a lot to take in, but these side effects are uncommon. If you don't have a history of heart disease or bladder problems, pioglitazone is generally safe and effective. With regular follow-up visits and routine blood tests, we can watch for any changes and make sure you stay on track safely.
What are the side effects of ivermectin? Is it safe at high doses?
That's a great question, and the answer is a bit more nuanced than you might think. Most of what we've learned about ivermectin over the years comes from its use as a single-dose treatment for parasitic infections, like river blindness. In those cases, people do often experience side effects, but here's the thing, a lot of the symptoms, like itching, rash, or fever, aren't actually from the drug itself. They come from the body reacting to the dying parasites. That reaction even has a name, Mazzotti reaction, and it's basically an immune flare-up, when large numbers of parasites are killed off quickly. But the more relevant data for people without parasite infections, like cancer patients or healthy individuals, comes from more recent studies, especially during the COVID-19 era, and in healthy volunteer trials. In those studies, ivermectin was tested at much higher doses, and for longer durations. We're talking about 15 milligrams daily for 7 days to 60 milligrams 3 times per week for 2 weeks. A single dose as high as 120 milligrams, which is around 2 milligrams per kilograms of body weight, that's 8 to 10 times the standard antiparasitic dose. And even at those high doses, ivermectin was generally well tolerated. No serious neurological problems were reported. The side effects people did report were mild, things like headache, dizziness, nausea, mild abdominal discomfort, and occasional loose stools. Merck even ran a dose escalation study to understand how the drug behaves in the body. They found that drug levels in the blood rose as the dose increased, just as expected. The half-life was around 18 hours. There was very little accumulation in the body, even when taken multiple times. Taking it with food boosted absorption significantly, more than 2.5 times higher than on an empty stomach. Now, what about using ivermectin in cancer care? As of 2025, there are no published clinical trials in humans testing ivermectin for cancer. Lab studies and animal models suggest it might have anti-cancer activity, but we don't yet have the human data to guide dosing or safety for that purpose. Bottom line? In people without parasite infections, like cancer patients or healthy volunteers, ivermectin seems to be quite safe, even at doses much higher than what's typically used for parasites. Most side effects are mild, and serious complications are rare. That said, because we don't yet have cancer-specific data, it's important to use caution and stay closely monitored if you're considering it off-label.
I heard that I need a high dose of ivermectin because I have a high-grade tumor. What's your take on this?
The dose of ivermectin we use is based on available safety data from clinical trials and what we know about its pharmacology, not just on how aggressive a tumor is. From a medical standpoint, all malignant tumors are serious and life-threatening, and we treat each case with great care and attention. But that doesn't mean using the highest possible dose of ivermectin is always the best approach. Higher doses can increase the risk of side effects without necessarily offering more benefit. We aim for a dose that balances safety and potential effectiveness. And we adjust as needed, based on your individual situation.
Dr. Zhang, I understand your point about high-dose ivermectin, but can you still write me a prescription for it if I really want to try it?
Yes, I can accommodate that, as long as you clearly understand the potential risks, and acknowledge that this is being done at your request, not based on my standard recommendation. The typical dose we use is ivermectin 15 mg taken twice a day on Monday, Wednesday, and Friday, for 3 weeks on and 1 week off. If you choose a higher dose, there are 2 common approaches, either 60 mg 3 times per week for 2 weeks, or a single weekly dose as high as 120 mg. That 120 mg dose is roughly 2 mg per kilogram of body weight, about 8 to 10 times the usual antiparasitic dose. If you go with 60 mg, I recommend doing blood work, CBC and CMP, every 2 weeks. If you use 120 mg weekly, it's best to monitor labs weekly. These labs help us track your liver-kidney function and blood counts to ensure your safety throughout treatment.
What are the side effects of Celebrex?
That's a great question, and I'm glad you asked. Celebrex, also known by its generic name celecoxib, is a type of nonsteroidal anti-inflammatory drug, or NSAID. It works by blocking an enzyme called COX-2, which is involved in inflammation and pain. Unlike older NSAIDs, it tends to be easier on the stomach, but like any medication, it can have side effects. Let me walk you through what we typically see. Headache, which affects about 15% of people. Indigestion or heartburn, reported in about 10 to 13%. Upper respiratory tract symptoms, like mild congestion or cold symptoms, in around 10 to 11%. Diarrhea, which happens in 8 to 10%. Abdominal pain and nausea, seen in about 5 to 8% of patients. Some people may experience occasional side effects like vomiting, 3 to 5%, skin rash, 2 to 4%, gas or bloating, 2 to 3%, mild swelling in the hands or feet, 2 to 3%, dizziness, 2 to 3%. Less commonly we see mild and reversible increases in liver enzymes like ALT or AST, 1 to 2%, slight elevation in BUN, kidney function marker, which is usually transient. Overall, Celebrex is considered safe and effective for most patients, especially when used short-term or at the lowest effective dose. Compared to traditional NSAIDs like ibuprofen or naproxen, Celebrex has a lower risk of gastrointestinal ulcers or bleeding. Of course, if you have a history of heart, kidney or liver problems, or are taking other medications, we'll monitor a bit more closely. If you ever notice symptoms that are new or concerning, I encourage you to reach out so we can evaluate whether the medication is still appropriate for you.
Dr. Zhang, thank you. Is there any serious side effect of Celebrex I need to be aware of?
This medication is generally safe, but there are a few rare side effects you should know about. They happen in less than 1% of people, but I still want you to be aware. These include things like GI bleeding, stomach ulcers or even a perforation, heart attack, stroke, congestive heart failure, kidney problems, and liver injury. These are uncommon, and in fact most people never experience them. The risk goes up if someone takes a high dose, stays on it long term, or already has heart, kidney or liver issues. That is exactly why we keep an eye on your labs and adjust the dose when needed. When it is used at the right dose for the right reason, Celebrex is usually safe and well tolerated.
What are the side effects of disulfiram? Are there any serious ones I should know about?
Disulfiram is generally well tolerated for most people, especially at standard doses, but there are a few serious reactions you should know about, even though they are rare. A disulfiram and alcohol reaction is almost guaranteed if any alcohol is consumed. It can cause flushing, chest pain, vomiting, low blood pressure, and confusion, and can become dangerous if someone drinks a large amount of alcohol. Psychosis is uncommon, but it has been reported, especially at higher doses or in people with a psychiatric history. Liver irritation can happen as well. Mild liver enzyme elevations show up in some patients, but true liver injury is very rare. If it does happen, we stop the medication. Peripheral neuropathy is also rare. It can show up as numbness, tingling, or burning sensations in the hands or feet. And there is a very rare condition called optic neuritis. This has only been described in a few case reports. Overall, these reactions are uncommon, but knowing them helps us monitor you precisely and use the medication safely. As I just mentioned, common reactions to disulfiram are usually mild, but it is important to know what can happen. The most common issue is the disulfiram alcohol reaction. Even small amounts of alcohol can cause flushing, headache, sweating, nausea, and palpitations. This reaction occurs in almost all patients who consume alcohol. A rash shows up in about 10% of people. Drowsiness happens in roughly 10 to 15%. Impotence or reduced libido occurs in around 5 to 10%. Headaches appear in about 10%, and acne shows up in roughly 5 to 10%. Many people also notice a metallic or garlic-like taste. That one is very common, affecting about 10 to 20% of patients. Because the alcohol reaction can happen even with tiny amounts of alcohol from cooking or mouthwash, it is best to avoid all alcohol-containing products. Most of these side effects fade once the medication is stopped. Liver function should be monitored regularly, especially during the first few months.
Dr. Zhang, what are the side effects of hydroxychloroquine? Should I be concerned?
That's a very reasonable question. Hydroxychloroquine is generally well tolerated, especially at standard doses and when used for shorter periods. But like any medication, it does come with some possible side effects. The most common side effects are usually mild. Nausea and abdominal discomfort happen in about 5 to 10% of patients. Vomiting and diarrhea show up a bit less often, around 3 to 6%. A small number of people, about 1 to 3%, notice mild vision changes early on, such as blurry vision or trouble focusing. These symptoms usually improve once the dose is adjusted or the medication is stopped. There are also rare but more serious effects, all occurring in less than 1% of patients. Retinal toxicity, or retinopathy, is the one most people have heard about. The risk is roughly 1% after 5 years of use, and it can increase to around 20% after 20 years. That is exactly why regular eye exams are so important for anyone on long-term therapy. Hemolytic anemia can occur in people with G6PD deficiency, but it is rare. Agranulocytosis, which is a drop in white blood cells, is extremely uncommon. QT interval prolongation can happen as well, but usually in patients who are on other medications that affect heart rhythm. And fulminant liver failure is extremely rare, though we still check liver tests from time to time as a precaution. In summary, hydroxychloroquine is considered safe for most people when it is used appropriately and monitored closely. We tailor the dose to your situation and follow you regularly to minimize any potential risks.
Dr. Zhang, what are the side effects of mebendazole? Is it safe to take?
For most people taking mebendazole, it is generally very safe and well tolerated. The most common side effects are mild. You might feel some abdominal discomfort, or a bit of cramping, maybe some diarrhea. A few people get a mild skin rash. These symptoms usually fade on their own, and they do not need any treatment. If someone is on longer use, or higher dose treatment, there are a few rare but serious side effects to keep in mind. These include liver inflammation, or hepatitis, and changes in liver enzymes on blood work. These changes are usually reversible. Low white blood cell counts can occur. Things like neutropenia, or even agranulocytosis. These are very rare. In extremely rare cases, seizures have been reported, and so have allergic reactions, including angioedema.
Dr. Zhang, what are the side effects of niclosamide? Is it generally safe?
Yes, niclosamide is considered one of the better tolerated antiparasitic drugs. It has been around for decades, and it is mainly used to treat tapeworm infections. Most of the side effects are mild, and they usually resolve on their own. The most commonly reported include abdominal discomfort, or cramping. That happens in about 3 to 5% of patients. Nausea and vomiting can occur, roughly 2 to 4%. Diarrhea shows up in around 2 to 3%. Some people notice an unpleasant or metallic taste. That is reported by about 1 to 2%. Occasionally, people experience a headache or dizziness. These are less common, usually under 2%. Overall, serious side effects are very rare. Most people tolerate it quite well.
My next question, Dr. Zhang, what are the side effects of doxycycline?
Doxycycline is generally well tolerated, especially when taken correctly. But like any medication, it can cause side effects. The most common ones are gastrointestinal. Nausea happens in about 5 to 10% of people. Vomiting occurs in around 2 to 5%. You might also get mild diarrhea, usually in about 1 to 5% of cases. It is actually less common than with other antibiotics, because doxycycline is so well absorbed in the gut. If the pill is taken without enough water, or taken right before lying down, it can cause esophagitis, or esophageal ulcers. That is uncommon, usually under 1%. We also see occasional skin reactions. A rash shows up in 1 to 3% of people. And photosensitivity can occur. Your skin becomes more sensitive to sunlight. That happens in about 1 to 4%. In rare cases, doxycycline can affect the liver. It may cause mild liver enzyme elevations, or even hepatic toxicity. This is seen in less than 1% of patients. It can also cause a mild and dose-related increase in BUN, a kidney marker. Most people do not feel this. It usually shows up only on lab work. As long as you take it with a full glass of water, and avoid lying down right away, most of these side effects are avoidable, or manageable.
What are the side effects of itraconazole? Is it generally well tolerated?
Yes, itraconazole is generally well tolerated by most patients. But it is a medication that needs a little more attention. It can interact with many other drugs. So we always check for drug-drug interactions before starting it. In terms of side effects, here is what we see. Based on clinical data and post-marketing experience. Common side effects happen in about 1 to 10% of patients. Nausea occurs in about 3 to 9%. Vomiting in 2 to 6%. Diarrhea in 3 to 7%. Abdominal discomfort or indigestion. That shows up in 1 to 5%. Headache and dizziness occur in 1 to 4%. Skin rash also appears in 1 to 4%. Peripheral edema can happen. Often dose-related. That is about 2 to 5%. Elevated liver enzymes are seen in 2 to 5% as well. Less common, but more serious side effects occur in fewer than 1%. These include liver toxicity, with rare cases of liver failure. Congestive heart failure can occur. This is important enough to carry a black box warning, especially with long-term use, or in patients with existing heart issues. Pancreatitis has been reported too. We monitor liver function during treatment, and we stay alert for any symptoms that might point to heart or liver issues.
Now, Dr. Zhang, what are the possible side effects of sulfasalazine? Is it generally safe to use long-term?
Sulfasalazine is widely used for inflammatory conditions. And for many patients, it works well, and is usually well tolerated. Still, like any medication, it can cause side effects. Some are common and mild. Others are rare, but more serious. Let's start with the common ones. Headache is the most frequent. It happens in about 10 to 20% of people. Nausea and vomiting come next. Those occur in roughly 5 to 15%. Indigestion and abdominal pain can also appear, usually in about 3 to 8%. We sometimes see changes in liver enzymes. AST and ALT may go up. There can also be mild leukopenia, a low white blood cell count. Hemolytic anemia can happen as well. That means red blood cells break down more quickly. In men, sulfasalazine can temporarily lower sperm counts. This is known as oligospermia, and it usually improves after the medication is stopped. Sensitivity to sunlight is possible too. That's photosensitivity. And on the rare side, there may be blood in the urine. That is hematuria. Or occasionally, crystal deposits in the urine. Again, as I said before, less common but serious side effects can occur. They happen in less than 1% of people. These include liver toxicity, such as hepatitis, or cholestatic jaundice. Kidney toxicity can also occur. Things like interstitial nephritis, or kidney failure. Lung inflammation is possible too, including eosinophilic pneumonia, or pleuritis. Pancreatitis has been reported as well. We monitor labs regularly, especially liver and kidney function, and blood counts.
Metformin is one of the most commonly used medications. Do you have any concerns about using it in cancer patients?
You're absolutely right. Millions of people in the US take metformin, and its long history of use tells us a lot about its overall safety. That said, when we use it in cancer care, especially off-label, we pay closer attention to tolerability and to the side effect profile. The most common issue we see is diarrhea. It can affect up to 20% of patients, especially with the immediate release form. In some people, it can be bothersome enough to require a dose reduction or a switch in formulation. Here is a quick rundown of common side effects. These occur in 1% or more of users. Diarrhea, 10 to 20%. Nausea, 5 to 10%. Vomiting, 2 to 5%. Gas or bloating, 1 to 5%. Abdominal cramping, 2 to 5%. Indigestion, 1 to 4%. Appetite loss, 1 to 3%. Fatigue or weakness, 1 to 3%. Metallic taste, 1 to 2%. Headache, 1 to 2%. Skin rash, around 1%. Vitamin B12 deficiency can occur, about 6 to 9% with long-term use. Ovulation induction can happen, often seen in women with PCOS. Not a side effect, but a pharmacologic effect. Serious but rare side effects occur in less than 1%. Lactic acidosis is very rare, but serious. Mostly seen in people with kidney problems or acute illness. Megaloblastic anemia can occur, usually due to B12 deficiency. Liver toxicity is very rare. Just isolated reports. For patients who develop intolerable gastrointestinal side effects, especially diarrhea, we often use a transdermal formulation of metformin. Because it bypasses the gut, it can eliminate GI side effects altogether, while still delivering the drug's benefits, especially in cancer patients, where gut sensitivity is more common.
Dr. Zhang, my last medicine is dimethyl fumarate. What are the side effects of dimethyl fumarate?
The most common side effects we see with DMF are gastrointestinal tract. Things like diarrhea, abdominal pain, nausea, and vomiting. Another frequent issue is flushing. It can affect 30 to 40% of patients, especially during the first month. Most cases are mild, but a small number of patients may experience more intense flushing, sometimes enough to stop the medication. Here are the numbers. Flushing, 30 to 40%. Abdominal pain, 10 to 18%. Diarrhea, 10 to 14%. Nausea, 10 to 12%. Vomiting, 6 to 8%. Itching, pruritus, 2 to 5%. Rash, 2 to 4%. Indigestion, dyspepsia, 2 to 4%. AST elevation, 1 to 2%. Mild to moderate lymphopenia, 2 to 6%. Usually temporary. Serious but less common side effects occur in less than 1%. PML, progressive multifocal leukoencephalopathy, is very rare but serious. Mainly seen in patients with severe or prolonged lymphopenia. Prolonged lymphopenia itself can last more than 6 months. Interestingly, in certain cancers like lymphocytic leukemia, this is sometimes used as part of a therapeutic strategy. Liver injury is rare. It can include elevated liver enzymes or hepatitis. Acute pancreatitis has also been reported. Very rare.
Dr. Zhang, it seems that liver toxicity is a big concern. Which medicines are the most worrisome?
You are right. It's one of the key things we watch for, especially when patients are on multiple medications. If the patient's liver function lab test comes back abnormal, we look closely at which drug might be responsible. And usually, we stop the one most likely to affect the liver. The good news is this. Most of the time, it's reversible, especially when we catch it early. That's why I always recommend checking blood tests and labs every 1 or 3 months. When we look at liver safety across your whole medication list we commonly use, the drugs fall into 3 clear groups: high risk, moderate risk, and low risk. This gives us a roadmap for what to adjust first if the liver panel goes up. And it keeps treatment safe and steady. Let's go through them. First, the high-risk group. These are medications that can raise liver enzymes in 5% or more of patients, or drugs with a well-known pattern of liver injury. Itraconazole can raise liver enzymes in up to 10% of patients. And although rare, serious liver damage has been reported. Disulfiram causes 3 to 10% elevations. It can trigger hepatitis, sometimes severe. Pioglitazone raises enzymes in 2 to 5%. Rare cases of liver failure have occurred. Diclofenac, especially the extended release form, can raise enzymes in 5 to 15% of users. 2 to 4% can go above 3 times the normal limit. And it can cause rare but serious hepatitis. Dimethyl fumarate increases liver enzymes in 5 to 10%. Severe liver injury is rare, but it has been documented. These medications are the ones we look at first if the liver numbers rise. Next, the moderate risk group. These raise liver enzymes in about 1 to 4% of patients. Clinically important liver injury is possible, but it's uncommon. Celecoxib raises enzymes in 1 to 3%. Pitavastatin raises them in 1 to 2%. Hydroxychloroquine raises them in about 1 to 2%. Sulfasalazine raises them in 1 to 3%. Mebendazole moves into this group when it's used long-term or at higher doses. Short courses are low risk, but prolonged therapy can cause enzyme elevations. Ivermectin also fits into this group when it's given long-term or at higher doses. Standard single-dose treatment is low risk, but extended use may increase the chance of liver abnormalities. These medications form the second tier we review when LFTs rise. Finally, the low-risk group. These medications have very little hepatic signal. Most have been used safely for decades. Doxycycline rarely causes enzyme elevations. Metformin is not inherently hepatotoxic. Niclosamide has minimal systemic absorption. Propranolol has only rare reports of liver abnormalities. Dipyridamole is also very low risk. These are the least likely to cause liver problems. When we put all of this together, the strategy becomes simple. If liver tests go up, we start with the high-risk group. Then we look at the moderate group. And only after that at the low-risk medications. This approach protects your liver, keeps your treatment on track, and helps us make safe adjustments without interrupting your care. I've put all three risk groups into one table for your easy reference. It gives you a quick way to see which medications are more likely to affect the liver, and which ones are less concerning. But there's one more point that's just as important. Maybe even more important. More often than not, liver enzyme elevations are caused by standard chemotherapy or immunotherapy rather than the off-label medications. So it's essential to talk with your treating oncologist. You want to review whether any of your current cancer treatments might be contributing to the changes in your liver tests. With more and more patients receiving immunotherapy today, we're seeing a rising number of cases with elevated liver enzymes. It's becoming more common. And it needs to be recognized early. Because when liver inflammation from immunotherapy is suspected, we have to act quickly. We may need to stop the chemotherapy or immunotherapy temporarily. And in many cases, we have to start high-dose steroids to calm the liver down and prevent further decline in liver function. The key is timely action. Catching it early. And working together with your oncology team to keep both your treatment and your liver safe.
I heard milk thistle can protect the liver. Can I take it for liver protection?
I get that question a lot, and honestly, I don't recommend it in your case. Here's why: your liver function tests, your LFTs, are one of the best tools we have to monitor how your liver is doing. The problem with milk thistle is that it might make those numbers look better on paper without actually fixing what's going on inside the liver. It doesn't stop fibrosis or reverse liver injury. So in a way, it can mask a problem by lowering the lab values while the real issue continues. That's risky because it might delay us from stopping a drug that's actually causing harm. So instead of adding milk thistle, it's much safer to keep checking your labs regularly and remove the medicine that's hurting the liver if we see any signs.
What should I do if I experience side effects after starting a new medication?
If you develop side effects after introducing a new medication, pause that specific drug and continue with the rest of your regimen. Once you've completed the full sequence of remaining medications, you can consider reintroducing the one that triggered the reaction. If the symptoms return, this helps confirm whether that particular medication is the cause. Share your observations with your care team so adjustments can be made to better suit your needs.
What if the side effects persist when I reintroduce the medication?
If the same side effects return upon reintroduction, it's a strong signal that the medication may not be well tolerated in its current form. In some cases, switching to an alternative formulation, such as from doxycycline hyclate to monohydrate, can reduce the adverse effects. It's important to discuss this with us, so the medication plan can be adjusted to maintain effectiveness while improving comfort and safety.
Is it common to experience side effects with these medications?
While we recommend a gradual introduction of each medication to carefully monitor for side effects, the reality is that most patients tolerate these medications well. Taking them slowly, one at a time, with space in between, gives your body time to adjust and reduces the risk of discomfort. In my experience, most individuals are able to complete the full protocol without significant or disruptive side effects. Occasionally, we do encounter the need to stop a medication. For instance, metformin may cause gastrointestinal upset in some people. But we have workarounds. Metformin can be compounded into a transdermal cream, which bypasses the stomach entirely and helps eliminate nausea or diarrhea. The key is communication. We're here to support you every step of the way, to manage side effects, make adjustments, and keep your treatment safe, tolerable, and effective.
My family doctor told me my cholesterol is too low, so I cannot take statins. What is your opinion?
It's understandable to be concerned about cholesterol levels becoming too low with statin use. However, numerous clinical trials indicate that it is safe to use statins even in patients with extremely low-density lipoprotein levels, including those with levels below 40 mg per deciliter. Therefore, I believe it is safe to take statins regardless of your cholesterol level. And remember, we use statins to treat cancer here, not solely for managing cholesterol.
I was told statins are bad for memory and the brain. Can they cause dementia?
That's a common concern, and I understand why. Back in 2012, the FDA did issue a warning that statins might cause short-term memory issues in some people. But they also said very clearly that the heart benefits of statins far outweigh those risks. More importantly, recent research has looked into this carefully, and there's no solid evidence linking statins to dementia. Some people have worried that lowering cholesterol too much might affect the brain, or that statins might cross into the brain and cause problems. But those are more theories than proven facts. One large study followed nearly 19,000 people over about 4.5 years and found no connection at all between statins and memory loss or dementia. So, based on everything we know right now, statins are considered safe for the brain, and they don't increase your risk of developing dementia.
Doxycycline is an antibiotic, and I'm worried about how it might affect my gut health. What do we know so far?
That's a great question, and one that comes up often. You're right to think about your gut health, it's important. So here's what we know. Doxycycline, like other antibiotics, can reduce the diversity of your gut microbiome while you're taking it. But the story's a little more nuanced than that. Interestingly, some studies show that doxycycline might lower the risk of C. diff infections, which are usually a sign of severe gut imbalance. It's also used in cases of small intestinal bacterial overgrowth, SIBO, so it's not all bad news. The even better news? For most people, the gut tends to bounce back pretty well. Research suggests the microbiome usually recovers within 1 to 4 weeks after stopping doxycycline. In cancer care, we often use a 2 months on, 1 month off cycle to give the gut time to reset. In some cases, like with patients on cetuximab, we even use doxycycline continuously to manage skin side effects. So, all things considered, when we use it thoughtfully, especially with breaks built in, doxycycline is generally safe for the gut.
Do I need to take probiotics if I'm on doxycycline?
While it's not strictly required, taking probiotics alongside doxycycline can be a thoughtful way to support your gut microbiome. Antibiotics can disrupt the balance of bacteria in your digestive tract, and probiotics may help restore that balance more quickly. We're supportive of using probiotics when appropriate. In fact, I often recommend them, especially during or after extended antibiotic use. Fermented foods such as kimchi, homemade yogurt, and kefir offer natural ways to maintain microbial health. If you prefer a supplement, look for one with multiple bacterial strains, which helps promote a diverse and resilient gut ecosystem. Trusted options include Bioccult and VSL number 3. Additionally, periodic microbiome testing, such as with Tiny Health fecal tests, can provide personalized insights and guide your gut health strategy over time.
My blood sugar is in the normal range. Is it safe to take metformin or Actos? And can both be taken together?
Yes, it is safe to use either metformin or pioglitazone, and even both together, even if your blood glucose levels are normal. These medications don't typically cause hypoglycemia when used alone, especially in patients who aren't on insulin or other glucose-lowering drugs. In oncology and metabolic health, we often use these medications for their broader benefits, such as reducing inflammation, improving insulin sensitivity, or targeting cancer metabolism. As always, we monitor your blood sugar regularly and adjust treatment as needed. If there are any signs that your glucose may be dropping too low, or if you have any symptoms, we can use a continuous glucose monitor, CGM, to get a clearer picture and manage things more precisely.
My kidney function is low, and my family doctor said I can't take metformin. What should I do?
That's a very valid concern. The safety of metformin really depends on how much the kidneys are affected. We base that decision on a number called the glomerular filtration rate, or GFR. That's basically the score that tells us how well your kidneys are filtering waste. Chronic kidney diseases are staged using GFR. Stage 1 means the GFR is 90 or higher, but there are other signs of kidney damage. Stage 2 runs from 60 to 89. Stage 3 ranges from 30 to 59, Stage 4 drops to 15 to 29. And Stage 5 is anything below 15, which is considered kidney failure. A lower GFR means the kidney damage is more serious. Someone is officially diagnosed with chronic kidney disease when the GFR stays below 60 for at least 3 months. Metformin is usually safe as long as the GFR is above 30. Once the GFR falls under 30, the risk of complications like lactic acidosis goes up, so we avoid metformin in that situation. We'll look at your latest kidney GFR numbers together. We'll go through exactly what they mean and make sure the plan fits your situation. And if metformin isn't the right match, we can explore other options that offer similar benefits but stay safe for your kidneys.
You know, I get that fenbendazole is technically a veterinary medicine, but can I still take it? I mean, is that even something worth looking into?
Fenbendazole is not approved by the FDA for human use. That said, I know many people with cancer are choosing to take it. From what I've personally seen in patients who've used fenbendazole, it seems to be well tolerated. But I want to be clear, I can't officially recommend or prescribe it because we don't have strong human clinical data to prove it's safe or effective in cancer. If you're thinking about trying it, the decision is ultimately up to you. Like with any medication, if you do take it, monitor yourself closely for side effects and let your doctor know. One thing I advise, avoid using Panicur, the veterinary version, because it's packed with fillers. Up to 80% of the dose is not the active ingredient, and this can make dosing tricky or even lead to taking too much. If you decide to go ahead, I suggest looking into sources that offer pure fenbendazole powder. Some patients have mentioned options like Happy Healing or Fenben Labs. I'm not endorsing any company here, just giving examples. To be honest, outside of a few case reports, there isn't solid clinical evidence yet. So while it might seem promising, it's still an experimental approach. Please keep that in mind as you make your decision.
Do I have to stop fenbendazole to take mebendazole, or can I take both? I've heard fenbendazole is better than mebendazole.
You don't necessarily have to stop fenbendazole to take mebendazole. Some people choose to use them together. That said, combining the two could be reasonably safe, but it does need careful monitoring. We'd want to watch for any side effects or unexpected interactions. Mebendazole is FDA approved for humans and something we can prescribe. Fenbendazole, on the other hand, is not officially approved for human use, so we rely more on case reports and patient experience rather than strong clinical studies. As for which one is better, there's no head-to-head study comparing them, so we really can't say one is clearly superior. Each has its own potential benefits, but until we have more solid data, it's hard to make a firm recommendation either way.
Dr. Zhang, we've spent a lot of time talking about side effects and safety concerns, and I get it. But I'm not taking these meds just to deal with side effects. Is there any actual data to support using them for benefits as a cancer treatment? I know they're not part of standard care.
Of course, we know these medications do have risks, but in most cases, the risks are relatively low and can be managed with proper monitoring. More importantly, based on current research and clinical experience, the potential benefits may outweigh the risks, especially when used as part of a carefully considered plan. I'd be glad to share some of the most relevant and up-to-date studies involving real cancer patients, so you can see the evidence behind the approach. So here's the deal with albendazole, it actually showed some promising results in early trials. They looked at 36 people with hard-to-treat solid tumors, and while the main issue was low blood counts, that's the medical way of saying bone marrow suppression, most folks just had mild side effects like fatigue and a bit of stomach upset. Now, out of 24 patients they could really evaluate, 4 of them, that's about 16%, showed a response in their tumor markers, which is a good sign. Plus, they also noticed that levels of VEGF, a protein tied to tumor growth, dropped too. Overall, people seemed to handle the drug pretty well on the schedule they tested. So for future studies, they're recommending 1,200 mg twice a day for 2 weeks, followed by a 1-week break, that makes it a 21-day cycle. The story of mebendazole in cancer treatment is complex. Early case reports and lab studies showed encouraging signs, leading some researchers to think this antiparasitic drug might have anti-cancer potential. But when larger follow-up studies were done, they couldn't confirm those benefits. In fact, a few raised safety concerns, including reports of unusually fast tumor growth. It's worth pointing out that those concerning outcomes came from studies using very high doses, much higher than what's typically used. In clinical practice, we stick with much lower doses and often combine mebendazole with other treatments. Based on our experience so far, we haven't seen any signs of rapid disease progression, though we still consider it an open question. One of the more well-known case reports involved a 74-year-old man with metastatic colon cancer. He had already gone through several lines of chemotherapy without success. He then received mebendazole at the standard antiparasitic dose, 100 mg twice daily, for 6 weeks. Remarkably, his follow-up scans showed a significant reduction in tumor burden, particularly in the lungs and lymph nodes. He had no side effects. On the other hand, a small phase 2 trial tested much higher doses, up to 4 grams a day, and didn't show any clear benefit. Worse, some patients actually experienced what's called hyperprogressive disease, where tumors grew faster while on treatment. That raised serious safety concerns. Here are the specifics from that phase 2 study. It was a small trial that escalated the dose dramatically, up to 4 grams per day, using the traditional maximally tolerated dose approach, even though mebendazole is not a chemotherapy agent. And the results were not encouraging. There was no meaningful benefit, and in fact, a number of patients experienced hyperprogressive disease, where tumors accelerated during treatment. That created significant safety concerns. What this study teaches us is precisely that higher is not necessarily better. It adds another piece of evidence pushing back against the long-held dogma of the maximally tolerated dose model. So, based on those cases, we keep mebendazole at a lower range, around 500 mg per day, and we rarely exceed 1000. I'm not a huge fan of high-dose mebendazole, especially when someone is considering it as a standalone therapy. For exactly these reasons, we take a careful and measured approach to dosing. A phase 1 trial out of UC Davis looked at using niclosamide in men with hormone-resistant prostate cancer, specifically metastatic castration-resistant prostate cancer. They combined niclosamide with abiraterone and prednisone. The combo was safe and pretty well tolerated. The most common side effect was some diarrhea, but overall it was manageable. Out of 8 patients they evaluated, 5 actually showed a drop in PSA levels, and 2 of those even hit undetectable PSA levels along with visible improvement on scans. That's pretty encouraging, especially in this hard-to-treat group. While this trial was focused on prostate cancer, the idea of combining niclosamide with other therapies might also have potential for other cancers. More research is definitely needed, but it's a good starting point. Here's what's really interesting. In this small study, 2 out of 8 patients had a complete and lasting response in both PSA levels and imaging. That's huge, especially when you consider that standard treatments alone usually only give about a 1% chance of a complete response. The clinical evidence for ivermectin in cancer is still very scarce, even though the lab data looks promising. It's surprising, in fact. Ivermectin has been used for decades as an antiparasitic and even explored for viral infections, but very little has been done in actual cancer trials. There is one case report that stands out. It involved 3 children with acute myeloblastic leukemia who had already gone through heavy treatment and were no longer responding. They were given high-dose ivermectin, about 1 mg per kilogram, either on its own or combined with RSC, a chemotherapy drug. 2 of the children improved. 1 had stable disease that lasted. Another had a complete blood response. The 3rd child did not respond, and that child received ivermectin alone. Even though this is a small, anecdotal report, it suggests something important. Ivermectin appeared safe, even at higher doses, up to 5 times the usual amount. And it seemed to work better when paired with chemotherapy. Still, there is a long way to go. We need real clinical trials to understand how to use it, when to use it, and what to use it with. Ocular adnexal lymphoma has been linked to chlamydophila infection, which is why doxycycline has been explored as a possible treatment. A study published in the Annals of Hematology in 2014 evaluated doxycycline as first-line therapy for ocular adnexal marginal zone B-cell lymphoma. 90 patients were included. Doxycycline was given at 100 mg twice a day for 3 weeks, for up to 2 cycles. The 5-year progression-free survival rate was 60%, and the overall survival rate at last follow-up was 100%. The best clinical evidence of itraconazole in cancer comes from a phase 2 study led by Johns Hopkins. This trial focused on men with metastatic castration-resistant prostate cancer, who had not yet received chemotherapy. A total of 46 patients were enrolled, and randomized, to receive either a low dose, 200 mg per day, or a high dose, 600 mg per day, of oral itraconazole, continued until disease progression or unacceptable side effects. At the 6-month mark, the results were striking. The high-dose itraconazole group had a PSA progression-free survival rate of 48%, compared to just 11% in the low-dose group. Itraconazole also led to favorable changes in circulating tumor cell counts, and showed suppression of hedgehog signaling in skin biopsy samples, a pathway implicated in tumor growth. What makes this especially interesting is that the anti-tumor effect was not driven by testosterone suppression. Serum testosterone and DHEAS levels remained unchanged, suggesting that itraconazole works through a non-hormonal mechanism, offering a potential alternative for patients aiming to delay or avoid standard hormone-directed therapies. There have been quite a few studies looking at statins and their role in cancer care. Overall, pitavastatin seems to stand out as one of the better options compared to the other statins. One of the most rigorous and elegant studies came out of Mass General Hospital in 2024. It was called the STOP-CA trial, a multi-center double-blind randomized study. They looked at treatment-naive lymphoma patients who were receiving anthracycline-based chemotherapy plus atorvastatin or placebo. The results are very encouraging. The complete response rate was higher in the chemotherapy plus atorvastatin group, 95% versus 85% in chemotherapy alone group. It wasn't statistically significant, but the difference is still worth noting. The rates of side effects were similar in both groups, which is reassuring that statin does not increase rate of side effects. Both the complete response rate and progression-free survival were numerically better with atorvastatin, even if not yet conclusive. These results suggest that atorvastatin might have a meaningful role when added to standard care chemotherapy. And based on its pharmacologic profile, I believe pitavastatin could deliver even more promising outcomes than atorvastatin in future studies. Let me tell you about a promising update in lung cancer treatment. A recent study published in JAMA Oncology has shown that adding a well-known diabetes drug, metformin, to EGFR-targeted therapies may significantly improve outcomes in patients with EGFR-mutated lung adenocarcinoma. In this trial, 139 patients were treated with standard tyrosine kinase inhibitors TKI, like erlotinib, afatinib or gefitinib. Among them, 69 also received metformin at a dose of 500 mg twice daily. After nearly 17 months of follow-up, the group receiving the combination therapy of TKI and metformin had a median progression-free survival of 13.1 months, compared to just 9.9 months in the group on TKIs alone. That's a 40% reduction in the risk of disease progression or death, a meaningful difference in cancer care. And it doesn't stop there. The median overall survival jumped from 17.5 months in TKI alone group, to 31.7 months with the addition of metformin to standard TKI. The objective response rate also improved significantly, from 54.3% to 71%. This research adds to the growing evidence that repurposed medications, like metformin, may play an important role in enhancing the effectiveness of existing standard cancer therapies. Now let's take a closer look at how metformin might enhance chemotherapy outcomes in advanced lung cancer. Researchers at Johns Hopkins conducted a phase 2 open-label study, involving patients with advanced or metastatic non-small cell lung cancer who had never received chemotherapy before. Patients were randomized into two groups. One group, Arm A, was treated with carboplatin paclitaxel and bevacizumab, combined with metformin. The other group, Arm B, received the same chemotherapy regimen, but without metformin. After 4 to 6 cycles of induction chemotherapy, patients entered a maintenance phase with bevacizumab, either with or without metformin, continuing until disease progression. Although the trial was small, with just 25 participants, the outcomes are intriguing. In Arm A, the group receiving metformin and chemotherapy together, the 1-year progression-free survival rate reached 47%, a substantial improvement compared to the historical benchmark of 15%. Median overall survival in Arm A was 15.9 months, which is higher than the 13.9 months seen in Arm B with chemotherapy alone. Importantly, toxicity profiles were similar between both two groups. This study is among the first to suggest that metformin may enhance progression-free survival in advanced stage lung cancer, when used alongside standard chemotherapy. It opens the door to further exploration of metformin's potential in oncology. Let's shift our focus to another well-known diabetes medication, pioglitazone, commercially known as Octos, and its potential role in targeting chronic myeloid leukemia stem cells. These quiescent stem cells are particularly resistant to standard therapies, making them a key challenge in achieving long-term remission. A phase 2 clinical trial, known as the ACTIM study, investigated whether adding pioglitazone to imatinib could help reduce CML residual disease. 24 patients were enrolled and received pioglitazone at daily doses between 30 and 45 mg, in addition to their regular imatinib regimen. Notably, no drug interactions were observed. The results were promising. Within 12 months, 56% of patients achieved a deep molecular response. Even more striking, among those who continued treatment for 48 months, 88% reached deep molecular response. For context, in a parallel group treated with imatinib alone, the 12-month conversion rate to deep molecular response was only about 23%. This study suggests that pioglitazone could significantly enhance molecular remission rates in CML, when combined with existing therapy imatinib. Now let's examine celecoxib, a COX-2 inhibitor more commonly known as Celebrex, and its potential role in reducing colon cancer recurrence. One of the most rigorously conducted studies involved 2,526 patients with stage 3 colon cancer. All patients received adjuvant FOLFOX chemotherapy, either for 3 or 6 months, and were then randomized to receive either celecoxib, 400 mg daily for 3 years, or a placebo. The results showed a modest improvement in outcomes for the celecoxib group. After 3 years, the disease-free survival rate was 76.3%, compared to 73.4% in the placebo group. At 5 years, overall survival was 84.3% with celecoxib versus 81.6% with placebo. While these differences may seem small, they fall well within the expected range for adjuvant chemotherapy trials. This study suggests a possible benefit of celecoxib in improving long-term outcomes for patients with stage 3 colon cancer, and supports further investigation into its role in adjuvant therapy. Dr. Isikoff at UCLA explored the addition of dipyridamole to a chemotherapy regimen, combining 5-FU and mitomycin, in patients with pancreatic cancer. In the study, 50 patients were enrolled, and 27 survived beyond 1 year, giving a 1-year survival rate of 54%. The most common side effect reported was stomatitis, or mouth inflammation. 3 patients developed hemolytic uremic syndrome, which was reversible, and 5 experienced grade 4 toxicity. These findings highlight the potential of dual biochemical modulation with 5-FU mitomycin and dipyridamole. This approach may not only extend survival, but also increase the chances of making previously unresectable pancreatic tumors surgically operable. At the University of Pittsburgh, a randomized controlled trial was conducted to assess whether adding hydroxychloroquine, an inhibitor of autophagy, could improve outcomes for patients with potentially resectable pancreatic cancer. Patients received 2 cycles of preoperative chemotherapy with gemcitabine and nab-paclitaxel, either alone or combined with hydroxychloroquine, followed by surgery. The results were striking. Those who received hydroxychloroquine had significantly improved histopathologic responses. Notably, the addition of hydroxychloroquine did not increase the rate of serious adverse events, and both groups completed a comparable number of chemotherapy doses. Beyond the improved tumor response, tissue samples from the hydroxychloroquine arm showed clear signs of autophagy inhibition, and a greater influx of immune cells into the tumor microenvironment. This suggests that hydroxychloroquine may enhance not only the direct cytotoxic effects of chemotherapy, but also modulate the immune response, potentially making tumors more amenable to surgical resection. Dimethyl fumarate has emerged as a promising agent in cancer research, particularly due to its ability to inhibit NF-kappa B, and selectively target cancers with KRAS mutations, an area of unmet clinical need. Building on these preclinical insights, Dr. Nicolay and colleagues at University of Heidelberg conducted a multicenter phase 2 clinical trial to evaluate the efficacy of oral dimethyl fumarate in patients with cutaneous T-cell lymphoma, spanning stages from stage 1 to stage 4. Over a 24-week treatment period, 25 patients received oral dimethyl fumarate. Skin assessments revealed that 7 out of 23 evaluable patients, around 30%, experienced a significant response, defined as more than a 50% reduction in lymphoma score. Notably, patients with a higher tumor burden, both in the skin and peripheral blood, were the most likely to benefit from dimethyl fumarate therapy. These findings suggest that dimethyl fumarate holds therapeutic potential, particularly for patients with advanced or high-burden CTCL.
Those are very exciting and relevant patient results from real cancer cases. But I didn't see any clinical trials for my specific type of cancer. Can I still take the medicine even if there's no trial data for my cancer?
Yes, it's definitely possible. The truth is, it's very difficult to study every single medicine in every single type of cancer. It takes time, funding, and large patient populations. But in integrative oncology, we often look deeper at the biology and behavior of cancer itself, not just where it started in the body. Cancers across different types often share common features, or what we call the hallmarks of cancer. That's why it's reasonable to believe that findings from a trial in one cancer may still apply to others, especially when we understand how a drug works at the molecular level. That said, we always acknowledge the limits. We may not have definitive data for your exact cancer. Also, we're not using these medicines one at a time, we're combining them into a treatment cocktail. This strategy may target several cancer pathways at once, which could increase the chance of benefit. Ultimately, the decision to use these off-label medicines is made together, through shared decision-making. They're not part of standard care, and you're never obligated to take them. But based on what I've seen, I truly believe they offer meaningful benefits to many patients, and potentially to you as well. We'll monitor carefully and adjust the plan as needed.
Dr. Zhang, you prescribed me some off-label meds. But when I talked to my oncologist, they warned me that these drugs, like metformin, zopitamag, and itraconazole, could cause nausea, vomiting, diarrhea, and liver damage. They said these could make chemo worse and advised me not to take them. What's your take on this?
First of all, I really appreciate that your oncologist took the time to look into these medications. It shows they're genuinely concerned about your safety and well-being, which is a good thing. That said, while the potential side effects are real and well recognized, I believe their risks are manageable, and do not necessarily outweigh their benefits in cancer care. These medications are used thoughtfully, and under proper medical supervision. These off-label therapies are not given casually. We prescribe them with intention and precision, monitoring closely for any adverse effects. While some side effects may overlap with those of chemotherapy, in practice, most patients tolerate them well. In rare cases where side effects become an issue, we adjust the dose, or pause the medication. My approach is not to dismiss these concerns, but to use clinical judgment, patient-specific context, and regular monitoring, to guide safe and effective treatment. Ultimately, we are aiming to support your therapy, not hinder it, and I remain open to collaborating with your oncology team, to make sure we all work together in your best interest.
My oncology doctor told me to stop the off-label medicines because there's no strong evidence they help, and they're not part of the standard of care. What should I do?
This is an important and thoughtful concern. It's true, off-label medications are not part of standard oncology guidelines, and we fully acknowledge that. These treatments are not intended to replace standard care, but rather to complement it, based on emerging scientific understanding and clinical experience. To our knowledge, the medications we use have a strong safety profile, and generally do not interfere with conventional therapies. That said, if your treating oncologist has specific concerns, we welcome an open and respectful conversation. Our goal is to align with your care team, and ensure your treatment remains safe and effective. If credible data shows that any of the medications we use could be harmful in your situation, we are always prepared to listen and make appropriate changes. Ultimately, your safety and well-being come first.
Dr. Zhang, my oncology doctor, reviewed my off-label medicines carefully and told me to stop all of them because he believes they're too dangerous. He said if I don't stop, I need to find another oncologist. I like my doctor and don't want to leave him. What's the best way forward?
That's a real dilemma, and I understand how hard this must be for you. If your doctor has a specific concern about one of the off-label medications, something he believes could seriously harm your health, we're open to hearing that and reviewing it together. We're flexible and willing to adjust your treatment if there's a clear medical reason. But if your doctor completely rejects the use of off-label medications, without any discussion, that may reflect a deeper difference in philosophy of cancer care. Our approach is based on shared decision-making, which means, you, as the patient, should be part of the conversation, when weighing risks and benefits, especially in complex cases, where standard options are limited or exhausted. In the end, you have two paths. You can choose to stop the off-label medications, if you feel the concerns are valid, and want to stay under your current doctor's care. Or, if you still believe in this approach, and want to continue, you may need to find another oncologist, who is more open to working with you through shared decision-making. We will support you either way, and help make sure your care stays coordinated, and focused on your goals.
Hi, Dr. Zhang, good to see you. I have some questions too. Can I continue with my standard cancer treatments, while on the Omega Precision Oncology off-label medicine cocktail?
Yes, the Omega Precision Oncology off-label medicine cocktail is designed to complement your standard treatments. It is not a choice between two paths. It brings both approaches together. They work side by side. Keep all your healthcare providers informed about every medication and therapy you use. This keeps your care coordinated, safe, and aligned with your goals.
Can I just take the Omega Precision Oncology off-label meds without doing standard treatments like chemotherapy or immunotherapy?
We don't recommend using the Omega off-label medicine cocktail as a substitute for standard cancer treatments. These medications are meant to work alongside treatments like chemotherapy, immunotherapy, or radiation, not replace them. It's important to stay on your standard care plan unless your oncology team advises otherwise. Using both approaches together may offer the best chance for results.
I've finished all my standard cancer treatments. Can I still take the Omega off-label medications?
Yes, you can take the Omega Precision Oncology off-label medicine cocktail even if you've completed your standard treatments, especially if your oncologist agrees that no further standard care is needed right now. These medications may still help slow down cancer growth or recurrence, even when you're not on chemotherapy, radiation, or immunotherapy.
I'm doing well on chemotherapy, and my oncologist says I've had an excellent response. Do I still need extra medicine like the Omega protocol?
Yes, even if you're responding well to chemotherapy, it can still be helpful to consider adding the Omega Precision Oncology off-label medicine cocktail. These are low-toxicity medications that may help target cancer cells in different ways, like interfering with cancer metabolism, inflammation, or resistance pathways. The goal is to strengthen your current treatment and reduce the chance of recurrence by hitting cancer from multiple angles.
I'm on immunotherapy. Should I take the Omega off-label medicine cocktail?
Yes, you can take the Omega Precision Oncology off-label medicine cocktail while on immunotherapy. In fact, some of the medications we use, like hydroxychloroquine, may actually enhance the effects of immunotherapy by modulating immune responses and reducing resistance. However, we usually avoid using doxycycline in patients actively receiving immunotherapy because it may alter the gut microbiome in a way that could reduce the effectiveness of immunotherapy. Each case is unique, so we would tailor the regimen to best support your current treatment.
Dr. Zhang, I'm currently participating in a clinical trial. Can I still take the Omega off-label medications?
This can be a bit complicated. From a medical standpoint, it might be reasonable to take the Omega Precision Oncology off-label medicine cocktail while enrolled in a clinical trial, but it really depends on your specific case and the rules of the trial you're in. Even if we review your records and determine that the off-label medications are medically appropriate and not likely to cause harmful drug interactions, the final decision belongs to the clinical trial doctor or sponsor. Many trials have strict protocols that do not allow any non-standard treatments, including off-label medications. What we can do is to check for any potentially harmful interactions between the trial drug and our off-label medications and flag them if there are concerns. But we cannot recommend that you take our off-label medicines without approval from the clinical trial research team, as that could put your participation in the trial at risk.
I've already gone through several rounds of chemotherapy, but they didn't work. My oncologist has stopped treatment and placed me on hospice. Is the Omega protocol still an option for me?
I'm really sorry to hear what you're going through. Yes, the Omega Precision Oncology off-label medicine cocktail could still be an option. While it's usually recommended alongside standard cancer treatments, that doesn't mean it can't offer benefit on its own. Some patients have chosen to try it even after standard treatments have stopped, hoping to slow cancer progression. If you decide to move forward, we'd suggest monitoring your cancer markers or scans to help guide the next steps.
What is your success rate with the Omega Precision Oncology off-label medicine cocktail?
I don't have a precise percentage for success rates, and that's because each patient is different. In real-world practice at our clinic, we see patients with many different cancer types and stages, often using this cocktail alongside other treatments. That makes it hard to calculate an exact success rate. Still, I can say that many of our patients have had responses that exceeded expectations, sometimes even surprising their primary oncologists. The key is close monitoring, through imaging like CT or PET scans, or ctDNA such as Signatera or Guardant Reveal. That's how we track whether the approach is working and helping. One major advantage is that these medicines are generally well tolerated and much safer than most standard cancer treatments, which is why we believe they're worth considering for patients looking for more ways to stay in control of their disease.
How soon should I notice the benefits of the off-label medicine? Does it take several days or several months?
Great question. Most of these meds start circulating in your body within a few hours after you take them. But when it comes to actually making a difference against cancer, we're usually talking at least a month or more. That said, there's no one-size-fits-all answer. Every cancer behaves differently, some grow fast, others slow, and many patients are also on standard treatments like chemo or immunotherapy at the same time. So it's really hard to tell exactly when you'll start feeling a change. For most people, it's more of a gradual effect over several months rather than something immediate.
How are patients followed up, and how can I make an appointment?
Ongoing medical supervision is a key part of what we do at Omega Precision Oncology. Since your health status, labs, and standard treatments can change over time, we closely monitor everything and adjust your protocol as needed. Our goal is always to support your overall care. We typically schedule follow-up visits with your physician every 12 weeks. During these appointments, we review your lab results, check on your progress, and make any necessary adjustments to your treatment. In between, you'll also have check-ins with our cancer care navigator or nursing staff every 1 to 2 months, to make sure everything is on track, and to flag any issues that may need the doctor's attention. If you have questions or concerns at any time, you're welcome to contact us by phone, texting, or email. There's no extra charge for that. Appointments are focused on keeping your treatment safe, effective, and personalized.
Dr. Zhang, thank you. You've prescribed quite a few medicines for me, but I'm not someone who usually likes taking medication. I'm worried about side effects and don't feel comfortable taking all of them. How should I handle this?
That's a very reasonable concern, and you're not alone. Most people don't like taking a lot of medications. I want you to know that we take this seriously. We carefully check for drug-drug interactions, DDIs, using advanced databases and medical literature. Your safety is always a top priority, and we include lab monitoring to make sure everything stays on track. That said, if taking all the prescribed medications at once feels overwhelming, that's perfectly okay. You can start with just a few and slowly build up over time, or stick with the ones you feel most comfortable with. This is all part of shared decision-making. We're here to guide you, not to pressure you. The goal is to find a plan that fits your comfort level while still supporting your treatment.
Dr. Zhang, where should I get the medicines? How long does it take? Do I need to call someone?
We work with several pharmacies to handle the off-label medications. Some of these medicines, like mebendazole, need to be specially compounded. For compounded medications, we usually send the prescription to a compounding pharmacy such as Care First or Pharmacy Solutions. Both are experienced in preparing these types of treatments. For other medicines, we can send them to the local pharmacy of your choice, like CVS or Walgreens. The cost will depend on your insurance plan and the pharmacy's pricing. We don't control the prices. One exception is Zopetamag, pitavastatin. Because most insurance plans don't cover it well, we usually send it to Marley Drug, which offers a better cash price. You don't need to call the pharmacy, they will reach out to you once they've received and processed your prescription. Compounding pharmacies may take several days to prepare your medication. For standard prescriptions sent to local pharmacies, it might just take a few hours. If you haven't heard from the pharmacy or received your medication after a few days, and you're concerned, feel free to call our clinic. We'll be happy to check the status for you.
Thank you so much for all your insights today, Dr. Zhang. I know it's been a long conversation, and we've covered a lot of ground. Before we wrap up, do you have any final thoughts to leave us with?
I'm glad you asked. Let me leave you with something that has stayed with me for a long time. It comes from one of the oldest and wisest texts, the Bible. In Luke 10, verses 33 and 34, there's that familiar story of the Good Samaritan. When he finds the injured traveler, he doesn't just feel bad for him. He steps in to help. And what does he do? He pours on oil. And he pours on wine. That image has always spoken to me, especially in my role as a physician treating cancer patients. It's more than a medical reference from ancient times. There's deep symbolism there. I think of the oil as integrative medicine. It's gentle. It nourishes. It supports the body's own healing ability. Like the herbs, supplements, and nutrition plans we use to help patients recover and stay strong. And then there's the wine. Wine isn't gentle. It's sharp. It kills bacteria. It gets to the root of the problem. That is chemotherapy. It's powerful. It's necessary. But it can also be hard on the body. And here's the key. He used both. Not just the oil. Not just the wine. Because healing, true healing, often needs both. If we only use the oil, we might provide some comfort. But never cure. If we only use the wine, we might kill the disease. But we may harm the person in the process. Just like the high dose or maximally tolerated chemotherapy we use every day in clinic. But when we use both together, and when we pay attention to both, that's when things start to shift. That's when healing can begin. In my work, I see that every day. Patients do best when we balance both approaches. Integrative support and conventional treatment. It's not about choosing one or the other. It's about bringing them together. And off-label medications fit into that picture. They are like oil and wine. Or something in between. They fit into cancer biology. They fit into practical application. They are already FDA approved. They are not experimental. Even though they are not standard of care today. Therefore, we should do what the Samaritan did. With compassion. With wisdom. And with action. So if I had to sum it up, it's oil and wine. Kindness and strength. Healing and hope. That's the heart and the gist of what I try to do every day. Thank you for listening. Have a blessed day.